28-year-old biker walked into the ER, conscious, just minor abrasions, vital stable. But minutes later, he turned pale, sweaty, restless, and then collapsed. Fast scan showed free fluid. CT was done and it confirmed the worst. A ruptured spleen. He was bleeding inside. This was hypovolemic shock. Silent, rapid, and deadly. Hi, this is Mass Medical and let's learn hypovolemic shock, the ICU Simplified way. Hypovolemic shock is a life-threatening condition caused by a significant loss of blood or fluid. This reduces the amount of circulating volume in the body, leading to decreased tissue perfusion, organ dysfunction, and eventually death if not treated urgently. There are two main types, hemorrhagic and non-hemorrhagic. Hemorrhagic shock is due to blood loss, like trauma or GI bleeding. Non-hemorrhagic includes fluid loss from burns, diarrhea, or third spacing. But both lead to the same end problem, that is hypoperfusion. The key event is reduced preload. That means less blood returning to the heart, which in turn leads to lowering of the cardiac output. The body initially compensates with vasoconstriction and tachycardia, but once those mechanisms fail, organs start shutting down. Now looking into the causes of hypovolemic shock. Trauma is the most common cause, especially in young adults. But don't forget internal bleeding from ruptured ectopic, splenic rupture, or massive GI bleeds. In non-hemorrhagic cases, severe dehydration, burns, or pancreatitis can trigger shock. So what are the clinical features? Early signs include restlessness, cold clammy skin, tachycardia, and hypotension. As shock progresses, urine output drops, mental status deteriorates, and lactate rises. Remember, cold hands can mean hidden danger. How to diagnose? Diagnosis is clinical. Look for a patient with signs of low perfusion and a suspected cause of volume loss. Fast scan helps in trauma, and blood gas showing high lactate adds further support. Investigations. Essential tests include CBC, ABG, serum lactate, ECG, and a point-of-care ultrasound. A low hemoglobin may suggest blood loss. Collapsed IVC on ultrasound points to a low volume status. So, how to manage hypovolemic shock? Start with securing IV access and giving fluids, ideally crystalloids. If hemorrhagic, then initiate blood transfusion early. Stop the source, whether that's bleeding, diarrhea, or third space loss. Monitor response with vitals, urine output, and lactate levels. Preventing hypovolemic shock starts with early detection of fluid loss. Quick fluid resuscitation is critical. Avoid overuse of diuretics, especially in vulnerable patients. Always monitor vital signs closely. Falling BP or rising pulse are early alarms. Treat the root cause, whether bleeding or dehydration, and don't forget to educate patients at risk, like the elderly or surgical patients. So, coming back to case summary, our biker had minor injuries but was internally bleeding. His falling BP, cold extremities, and sweating were early red flags. Fast scan showed free fluid, a ruptured spleen. Prompt recognition and surgery saved him. That's the power of clinical suspicion. So let's try to revise everything rapidly. Hypovolemic shock is about volume loss, which in turn leads to decreased preload, and which in turn leads to decreased cardiac output. That leads to decreased perfusion. Key signs will be tachycardia, hypotension, cold peripheries. We have to investigate early and act fast, restore volume, and save the patient. Like this class? Don't forget to like, share, and subscribe to ICU Simplified. More case-based ICU lessons are coming. Stay tuned. Thank you for watching. Till then, take care. Bye-bye. Stay safe. Stay blessed.